Good afternoon, and thank you so much for joining us today. My name is Adam Hernandez, CEO of Infinity Consulting, and I'm joined by my colleagues Christiana Novakovic, Audrey Rowan, and Nicholas Ellis. We are very excited to show you what we believe is an incredible opportunity for the South Tree Health Network, and we'd like to show it to you today for the first time. Our overview for the next 20 minutes begins with understanding the current situation within the nation and the network. We'll walk you through our root cause analysis and reveal our solution designed to lift STHN from the stroke belt. We'll end with a thorough cost-benefit analysis and wrap up with some key points you should walk away with. So let's jump right in. Currently, we are struggling against escalating healthcare costs with spending reaching $3 trillion per year. A key component of that spending lies within stroke care. Stroke is the fourth leading cause of death within the United States, with 700,000 cases per year. 2/3 of stroke survivors require costly and lengthy rehabilitation. STHN is not immune from these national trends. Increasing incidence of stroke amongst its members translates into increased costs for the network. What brings us here today is Lynette Tate. Poor health education, combined with distance to available healthcare resources, all proved to be a barrier to successful care, all of which was exacerbated by her general mistrust of the healthcare system. What we found, however, is that Ms. Tate is not alone. She is representative of the general population within the network. When approaching her case, we did it in a fashion that would benefit not only Ms. Tate, but all patients like her within STHN. Lynette Tate's experience begins with transient ischemic attacks that remained unidentified due to poor stroke education. Upon having a stroke, the disorder in her initial care led her to develop aspiration pneumonia, setting back her discharge by 7 days. Upon discharge, her lacking support system, unsafe living conditions, and poor care coordination all conspired to leave her struggling with post-stroke disability. Examining each of the contributing factors led us to 5 categories that created an environment for her to struggle with poor stroke outcomes: the patient, support and caregivers, the hospital, contracted providers, and the network itself. Common to all of these were lapses in communication, coordination, and poor stroke education. We've identified these categories as opportunities for improving the health and safety of the community. Our mission stems from the fact that 5% of all Kentucky deaths are due to stroke. Within a network, stroke carries a 53% mortality rate. 40% of those that survive stroke are under the age of 65. This begs for fundamental changes to the way stroke patients experience care. Our mission, again, is to conduct a system-wide evaluation of stroke processes and recommend a comprehensive strategy that satisfies the triple aim: increasing quality, lowering treatment costs, and better access. My colleagues will now lead you through our solutions, beginning with our senior finance consultant.
Our main recommendation is that the South Tree Health Network become an accountable care organization through Medicare Services, or an ACO. So what exactly is an ACO? It's a legal entity by which the shared savings program that was begun under the Affordable Care Act 2010 is going to be implemented. And what that just means is a network really works to improve its quality while decreasing costs, and the shared savings are split between Medicare Services and the network. It's comprised of multiple providers. This can be any kind of healthcare provider, from an ophthalmologist to a podiatrist to a pediatrician, which is why it's perfect for an actual health network such as yourself. And it really focuses on that coordination of care. Rather than the fragmented care that we're seeing all over healthcare today, it really focuses on interdisciplinary coordination of an individual patient's care. It also has a limited risk. So rather than ACOs that were formed before the Affordable Care Act, this has no shared costs. So you do share in savings, but if you fail to meet those requirements, there are no shared costs. It's also a bundled payment system, which we know is something you as a network are looking to improve upon. instead of a typical fee-for-service model, you're going to be receiving one bundled payment for an individual patient and then disperse it to the providers as you see fit. This is just a visual representation of an ACO where you can see all of the providers are focused around the patient instead of one physician and all of the patients focused around him. In order to actually become an ACO, it's really important to have a fully integrated electronic health record system. Many of the problems with Ms. Lynette Tate's case stemmed from lack of communication between providers and their inability to actually see her patient records. With a fully integrated electronic health system, all of those lapses in communication will be fixed and we won't have that problem. So that will result in better patient safety and better quality of care. There are so many opportunities in an ACO. Among these are centralized population care and streamlined administration, all these things leading up to those reduced readmissions, reduced redundancy in tests, and lower cost, better quality care. So, the key to ACO implementation. The goal is those better health outcomes, but it's evidenced by quality measures. These are set by Medicare Services, and there are 33 of them. And these can range from readmission rates to patient satisfaction scores. And in year one, the pay for an ACO, that shared savings, is simply pay for reporting on those quality measures instead of actually meeting them. So by year two, once you've gotten all of your quality up, that's when you get the pay for performance, followed by year three, which is pay for performance as well. So how are we going to measure quality? We recommend using HCAHPS, the Hospital Consumer Assessment of Healthcare Providers and Systems. And this is just a visual representation of an HCAHPS report. It's simply a survey that's sent out, and it records all kinds of these quality measures. For example, how many patients would definitely recommend this hospital? We can set a target rate, say 67%, and we can look at it monthly and see, in this month, we fell below our target rate. So we know we need to work and look back and see what we did to decrease that quality. And in months that we far exceed our rate, we can go back and see what exactly we did well so we can replicate those measures. So the ACO costs and benefits. These numbers are straight from Medicare Services. The average implementation cost of an ACO is $2 million in the first year, followed by $3.5 million in the 2 following years. But the benefits and shared savings far exceed those costs at $5.4 million in the first year and $6.2 million in the second year. Since there's no data for the third year, we used a simple regression analysis and are forecasting $7 million in benefits in the third year. So looking at an ACO, we boiled down the goals to 3 main goals: preventative efforts, best practice care, and effective follow-up. So we are recommending 3 elements to our ACO status: community outreach, integrated stroke policy, and APN care coordinators, so that we can take our accountable care organization and provide care that is affordable, coordinated, and outreach. And now, our senior operations consultant.
Ms. Lynette Tate is a member of a community in need of health guidance and support. As a result, the first element of our solution focuses on implementing strong community outreach. And through this increased health knowledge, we hope that your network's members will be able to recognize the symptoms of a stroke and get to the hospital in time for successful treatment. We suggest hiring a community outreach coordinator who will work to coordinate your existing efforts, to utilize local and national resources, as well as heading an internship pilot program. Coordination is key. Currently, SDHN has multiple programs fostering stroke awareness and prevention, but they're highly uncoordinated and are in need of revising. The disorder causes redundancy and inefficiency, which can be gravely expensive. This outreach coordinator would synchronize these efforts, not only lowering costs, but also closing those gaps that your patients have reported falling through. Your network is in its best interest to form partnerships with local and national resources. The National Health Service Corps is a foundation working to bring interdisciplinary healthcare professionals to rural areas with the financial incentive of loan repayment and free tuition paid for by federal funds. This is a great asset for clinician recruitment and retention. Along those lines, the Area Health Education Center, AHEC, fosters the ability for healthcare students to come do their clinical rotations in your hospitals and facilities, which helps bring young and skilled potential employees to the area. But the partnerships don't stop there, as there are multiple other organizations with existing efforts that could work well right into your network. In a rural area, stroke survivors, such as Lynette Tate, may find themselves isolated. And if STHN can act as a facilitator to stroke survivor support groups, we can bring these survivors together with their families to have them share their experiences as well as their knowledge of local resources to help with social and psychological support. And this will improve their quality of life, not only for the patients themselves, but for their family members to have a greater understanding of what's going on with their loved ones. And community health screenings community health events and screening efforts will put STHN in a great position to gain trust from within the community and will draw in physicians, nurses, and healthcare professionals to volunteer their time to educate the public on the comorbid conditions of stroke so that we may be able to catch some of those strokes before they can occur. So we suggest implementing an internship pilot program by bringing in and reaching the community directly through its younger members. As this pyramid shows, by just a small group, you can affect an entire community, increasing that health knowledge, and you'll see far fewer unrecognized strokes. This program would draw in students from local high schools and colleges to work together on a volunteer basis under the outreach coordinator. They would create presentations to which they would go back to their respective schools and educate their classmates and teachers on what they have learned throughout the program. They will also help to organize several community events, some of which may be directly through their schools. And through this entire process, they will become community stroke ambassadors with the ability to recognize that their grandfather was having a stroke, or perhaps somebody that they passed by on the street. This program will effectively empower the students to make a real difference in the health of their communities, and will also show them the mechanisms of healthcare and public policy while building teamwork and leadership skills. For the costs, working closely with the outreach coordinator would be a grant writer who would help to apply for funds for these community efforts. We have budgeted an amount for community events, the grant applications, promotional materials such as flyers and presentations, and a workspace for the internship. In the first year, we have set a goal for about $40,000 to specifically cover the costs for the internship system. But this is just a starting point to the many other grant opportunities available from multiple organizations in the next several years. This element of our solution is the stepping stone to making southeastern Kentucky a more stroke-literate society. And now to our senior medical consultant.
Thank you, Audrey. Our second element is to implement a post-stroke dysphagia screening policy. One of the things that was a big element in Lynette Tate's care was the fact that while under our care, she developed aspiration pneumonia. So we all know that one of the telltale signs of stroke is the paralysis of those muscles of the face. What's equally common, but not quite as well known, is the fact that often muscles of the throat are paralyzed as well. When those muscles are paralyzed, water and food and other debris can get down into the lungs and cause a really unpleasant condition called aspiration pneumonia. So it can increase hospital stays up to 7 to 9 days, like it did in Lynette's case, and cost up to an additional $40,000 to treat. It's unfortunately all too common. 60% of all stroke patients will develop dysphagia at some point during their initial course of treatment. Aspiration pneumonia through dysphagia is the second most common cause of death due to stroke, with up to 20% of all of those dysphagic patients suffering and dying from aspiration pneumonia within the first year. So fortunately, the solution is fairly simple, just as easy as drinking from a glass of water. The patient drinks a small cup of water while under observation. If any of the water goes down where it's not supposed to, we'll see coughing, sputtering, difficulty breathing, and we'll know to refer them to a full swallow study by a speech pathologist. While this is going on, we simply hook them up to a pulse oximeter, standard in every hospital room, and measure the oxygen content in their blood. If anything gets in there and blocks the airway, we'll see it, and we'll be able to refer them for a full swallow study. So even just a 75% screening rate, like we discussed, reduced rates of aspiration pneumonia by up to 60%. This is also something that can reduce your liability. Full dysphagia screening policies are something that's recommended under the Kentucky Stroke Encounter Guidelines. What's more, it's low cost. This is highly effective. This is something that's completely in line with STHN's mission. What's more, it's both specific and sensitive. We're seeing only about $10,000 in additional formal swallow studies. With some minor training costs, but all of that is completely wiped out by the fact that we're seeing $420,000 due to those reduced rates of aspiration pneumonia. Our third element is to have practice care coordination by advanced practice nurses. One of the other elements that Adam mentioned during Lynette's treatment is that she tended to fall through the gaps in those critical care transition periods. We want to make sure that we have one person who's responsible for monitoring care from beginning to end, all the way out into the community, to make sure that those care transitions go smoothly and that we don't lose anyone into the cracks. So who exactly are these patients that we'd be recruiting? We identified 5 categories that had evidence suggesting that they were linked to poor outcomes post-stroke. In Lynette's case, her severe stroke and poor support system would have qualified her for entrance into this program. So why exactly an advanced practice nurse? First off, their advanced training in clinical decision-making makes them ideal for managing a complex disease such as stroke. They're able to get out into the community and recognize some of those potential comorbid conditions or potential complications that might result in readmission. Furthermore, their status as highly credentialed professionals makes them ideal for running and managing a interprofessional healthcare team. So we identified 3 roles that we want our APNs to fulfill. First off, education. Within 72 hours of admission, we want to make sure that we're getting in, seeing the patient and their caregivers, and beginning to create a relationship, providing education and creating a dialogue between the two. While this is going on, while they're still in the hospital and in rehab, we want to make sure that we're coordinating care, making sure that during those fundamental and important care transition periods that no one is falling through the cracks and that everything that is necessary is getting ordered. Furthermore, we all know that healthcare doesn't end when the person leaves the hospital or leaves rehab. We want to make sure that we're following these patients out into the community, into their homes, being available by phone after rehab discharge if they have any concerns or develop any new symptoms, but also visiting them in their homes to physically recognize those signs of relapse or any potential comorbid conditions that might have gone unrecognized through the whole process. So this is just a diagram that indicates that close and ongoing relationship between the patient and our APNs. That dialogue and education is what is going to give us new information that will be fed back into the patient's care team, resulting in better coordination of care and more focused and effective treatment. All of this reduces 24-week all-cause hospital readmissions by 50%. And when those readmissions do occur, they're shorter and they're lower cost. We save on average about $3,000 per patient enrolled in the program. What's more, this broad applicability for this program beyond just stroke. Evidence has shown it to be effective in cases as diverse as cardiac arrest, chronic kidney problems, and even orthopedic conditions such as broken hips. This is something that will grow with STHN as your organization grows. What's more, it's also cost effective, with the primary expense being for the APN and some limited administrative costs. However, all of those are completely occluded by the fact that we're seeing a $300,000 benefit from that reduced rates for care and that reduced readmission rates.
Using a simple 4-year cost-benefit analysis over our 4-year implementation plan, we looked at simply the 3 elements of our ACO: community outreach, updated dysphagia screening, and those APN care coordinators. So it's going to cost in capital of about $1 million, but the benefits of that and the savings are $2.7 million, leading to a total savings over those 4 years of $1.75 million. And then going back to those ACO savings, we projected $18.6 million in earnings from that shared savings program with those $9 million in invested capital. It's going to lead to a net income of $9.6 million over those 4 years.
We've designed a phased implementation approach where in the first phase we initiate each of these elements within a reasonable time frame. Our second phase begins with implementing each of these solutions, ensuring a good fit with our current staff and practices. The third phase focuses on maintaining our progress, followed by the fourth and final phase, wherein we assess to see if there remains anything we could still improve upon. We see that as these elements are implemented, the gaps that Ms. Tate fell through begin to be eliminated, achieving triple aim excellence. Our ACO vision of affordability, coordination, and outreach not only benefits Ms. Tate, but all patients like her within the community. These solutions are something we're each passionate about. We believe it will transform the way stroke patients experience care, making the South Street Health Network the model for stroke care nationwide. Thank you, and we'll take some questions.
Okay, thank you very much. We ready to go?
Sure.
I have a couple of questions. I'm curious you're thinking about investing in the dysphagia program versus sort of or in addition to an approach to the acute stroke and getting to drug more quickly and more acute services in the community before they get to our hospital. So talk through your thinking and what are our challenges and risks and concerns associated with that focus versus a focus on sort of getting to drug faster.
So we identified two elements that were critical to that decision. First off, the fact that it's a rural community, meaning that distance in and of itself puts some barriers in place for that. However, in Lynette's case, the primary barrier wasn't the fact that there was actual time to the medical care center or even time to needle once they got there. It was the fact that when she had her stroke, she didn't recognize what it was, called her caregivers, and there was a whole train of thought as to what's going on, what do we do? We figured that if we increase our outreach approaches, increase that stroke education, that will be our primary reason for that primary approach to decreasing that stroke to needle time.
Yeah. And about the APN coordinator, it's going to be one APN at one hospital managing 100. I think I saw a footnote or about 100 patients.
That's correct.
So it's a solution for one of the facilities in the network. And just to extend that question a little bit, and sometimes adding a role improves coordination and communication. Sometimes it adds a silo. So have you thought through how you'll integrate a new provider into an existing provider pool?
Yes, well, in forecasting the number of patients, we looked at the current number of patients with the South Street Health Network, and we looked at the incidence of stroke, and we looked at those that would be in that high-risk bracket. So that's how we got the 100 to 180 patients, and that's how we based that off of the APN care coordinator.
It's important to note that's 100 to 100 patients over the course of a year, not a stable of 100 patients at all times. So if you think about it, 40 hours a week, 52 weeks a year, that's actually quite a bit of time developed individually to those patients.
And one of the reasons we chose an APN care coordinator is their high level of training, as you mentioned. So they have that authority coming in to actually manage that healthcare team. So yes, the team will still be together and working together, but they do have that greater authority than simply, just any other practitioner.
And you mentioned them being a silo. These are nurses that we've chosen who have experience working and coordinating with multiple providers. So we see them not necessarily being a silo, but facilitating that exchange of information and really helping overall patient outcomes.
So in your financial analysis, I like the way that you presented your solution, then put the finances together. It was helpful that way. So tell me, you talk about savings dollars. How does that translate into real cash? Because you're talking about expense, and now I'm saving. It's like my wife going shopping and said, I saved you $100, and I spent $300. I mean, how does that work?
That's a good question.
Well, those savings, pardon me, I'm losing my voice, but those savings are going to definitely play into our historical costs and show that we are cutting those costs and improving that quality. So we're going to be really making sure we get those ACO benefits. So those costs that we're cutting, if that's the money that we normally would have spent historically, and we know we can implement that in other areas of the hospital.
It's important to note also that the ACO, when they talk about shared savings, it's coming in the form of a check from Medicare and Medicaid services. So the fact that we're saving Medicaid money and then they are then increasing our reimbursement and cutting us a check.
Yeah. So you're getting a DRG payment. So you're getting a fixed amount. So if you're saving money, you're not spending all of the money that you're getting. So another question is, you did mention about the electronic health record increasing communication. I was just wondering how that increases communication between places.
It's more of a means to, once a provider has entered information on a patient into a system and they make notes, make sure that a speech swallow study is ordered, or make sure that this patient is not discharged before this happens. In the case with Lynette Tate, there were notes within one system that never got carried over into another. So it's not so much the verbal communication as specific notes and a tracked patient record that would be able to be transmitted from hospital to rehab facility that would improve the overall care by continuing that communicated information specific to that patient.
Right, allowing that one line of thought to be available to all providers of that patient.
Yeah, just a comment. Someone still has to look.
Right.
That's true.
I want to get at a little bit of the ACO recommendation. It seems to be right in the center of what you're proposing there. So, when you first introduced it, you said a Medicare ACO. Now, so does that mean you only want to apply it to Medicare patients, or do you see it applying well beyond Medicare patients?
We see it applying well beyond Medicare patients, but because the model currently that has the most evidence behind it is the Medicare model, that's the one that we use as the basis for this, but we definitely see it expanding and covering all of them.
So, for example, Blue Cross plan that's part of our network,
part of
you
the
would see us approaching them. Well,
And these benefits not only directly affect Medicare and Medicaid patients, but they trickle down to all patients that are treated within STHN.
Now, right now we're relatively small as a network, yet we have major aspirations.
Right.
No pun intended, I might add.
We like to think of it as we're nimble.
Well, we're talking about growing to 100,000 members.
That's right.
And it seems to me you've got the cost of growth, you got the economies of scale, et cetera. Do you see this ACO status as and the continued shared savings as the model we ought to be under 5 years from now with 100,000 members?
Absolutely. We actually thought about the fact that you are a small but growing organization played heavily into this. We believe that the ACO and the accountable patient-centered model of care is the wave of the future. And actually the fact that y'all are a new organization is an undeniable benefit, because a lot of times when you see the changeover to ACO, the costs are coming in and that you have a massive corporate culture that needs to completely realign. As a new organization, this is something that puts you in at the ground floor, and it's something you can build your organization's values around.
Okay, because one of the questions we asked was regarding at some point in time taking on either partial or full capitation. So you're suggesting that even 5 years out that we won't be ready for that necessarily. What are you telling us?
I think, sorry, I think that an ACO is really a stepping stone more in a way, and we definitely want to build those values into our organization. We really want to move towards that value-based care just in general, and I think an ACO is the means to get there. I'm not sure if I'm conveying exactly what I'm thinking.
So one of the reasons we talked about the total cost of care arrangements was that they're very, very analytics driven. And as a small organization, we know that a lot of that's an extremely large expense, even if it would be partially offset by Blue Cross, Blue Shield. So we wanted to know that, first off, we want to make sure that we're staying and we're being, I suppose, ambitious, but still not stepping beyond the curve, that we're following what evidence has shown to be effective.
And that's also where our assessment stage comes in the 2 to 5 years bracket, so we can look at it and see how that's going to fulfill our needs in the next few years.
Okay, so let me restate what I think I've heard. You're saying the ACO because there's a reward sharing element. I mean, there's also a risk sharing element that evolves if under Medicare anyway. But that we should be doing this because we'll be implementing all these other things and we'll be getting at least some benefit as we're improving our processes,
Correct.
et cetera, and getting some results. And at some point in time down the road, we might want to take a further step,
Exactly.
Right.
be it sub-cap or
In fact, that's actually
capitation
the
type
fourth
arrangement.
phase of our implementation is we assess to see if there remains anything we could still improve upon. What's working, what's not working, and go off of that, driven by data.
Okay. Other questions from the judges? What? You have one? All right. Well, then I think we'll move into the feedback mode.
All right.
Okay. Which is new for those of us who
Yeah.
judged for a number of years, and actually I think we're enjoying it a lot. I even think you all
We're
are
gonna enjoy
enjoying it a lot. Number of things. I loved it when you came out and sort of, how do we lift the network from the stroke belt? That was a beautiful introductory comment. That was congratulations to whoever thought of that one. That was a good one. Again, using Lynette as the example and the recognition and emphasis that she's representative of many. That was a really good point
Correct.
to make, and I think, the root cause analysis I think was good, and that the recognition of the importance of caregivers came out of that, and I'm just trying to highlight certain
Absolutely.
things we maybe haven't heard every time. And I think family and caregivers, and then you also got into the Stroke Survivors Network. So it seems to me there's a whole social network support system
Very important.
that can and should occur that is it's about family, it's about other caregivers, religious persons, whatever it may be, and it's about folks who are going through the same thing. So I think those were good catches. I think your references to CMS projected costs provide a benchmark that make, as telling a group like us, here's what it's going to cost. You just sort of wonder, where these numbers come from.
Right.
But in this case, you told us,
Yeah, it
and
came straight.
that makes a comfort zone with regard to cost to evolve and develop that. So that felt good. The dysphagia screening was interesting. I wonder whether you're relying too much on that versus a number of other clinical interventions, but I liked that. And again, I'm not a clinician, so nonetheless sounded and made sense to me. And the idea that what we're doing, you did it in reference to advanced practice nurses, but you said what we'd be doing is relevant to other conditions. And an ACO is not made up of just stroke.
Exactly.
Stroke. Number of them will be at risk for stroke, but it's not just that. So the idea is some of this modeling of care processes and creating structures, et cetera, has got to be relevant across the board to the entire risk pool, which is another way of saying a whole lot of people with a whole lot of different diseases, et cetera.
That's
So
right.
nice job, and those were sort of the observations along the way.
Thank you.
Thank you.
Yeah, good job. I like it that you came out and behaved as consultants. Minor point, you need a logo.
We almost made one.
Just a minor point. It was really helpful. I liked when you came out and said, here's what we're going to do, and then proceeded. It really sets the framework for, I always think it's helpful for people to have a rubric or a place to put things in, and that was very helpful. Identifying the electronic health need is really, really important, because that is important. The community outreach coordinator, I think tying the community into this is really important, and you did a good job. I thought the community stroke ambassadors, the internship was unique
Yeah.
and creative. I wasn't quite sure how it really tied to, if it was a feel-good thing. I would want to see a little bit more substance, but it was unique. And as I mentioned before, it was really nice to see the finance right after the proposal, rather than seeing an analysis at the end.
Right.
It just kept me on focus. I wasn't sure why you didn't emphasize the acute stroke, and the explanation you gave actually made a lot of sense and caused me to think, oh, that's an interesting thought. Yeah, dysphagia is something we could deal with right away, and really she did get okay acute care, but it was getting to the
Right.
acute care that was important. So that was helpful clarification. Might have done that in the presentation, because that would have been a little interesting. You had good graphics, good presentation. Pay attention to who's speaking. Look at them. Show that they're important. But you guys did a great job.
Thank you very much.
Oh, two other things. And this is the clinician in me. You made reference to her case. Patients aren't cases. Just remember that. And the only other thing is, you started with facts, moved to emotion. I'm not sure that you wouldn't have engaged us quicker starting with emotion and then going to the facts. But you did a good job in capturing both. So otherwise, great job.
Thank you.
Great slides. You clearly put a ton of work into them, and they look great. They communicated your message. They were very clear. The timeline was a great device. It was really, really good. It was really clear, and coming back to it the way that you did was fantastic. I really liked that. I thought the balance sheets, actually, I liked that they were spaced where that they were, but I thought they felt a little under-supported. They didn't fully address for me the costs and the benefits in the way that you might want to see it in a balance sheet, but pretty small detail. I thought your answer was really good to the question about acute care. I thought it was just good that you had an answer. You clearly thought through it. There was a reason why you picked that program. It wasn't just an omission of the other aspects of acute stroke care. So I was impressed by that. So really good job, guys.
Thank you.
Thank you.
Appreciate it.
All right.